Alyson, thank you so much for joining me today on the Fempower Health podcast. I have been hearing so much about all these fascinating things that contribute to and impact chronic pelvic pain. And one of them, I have hypermobility, and really appreciate that you're willing to make time to come on the Fempower Health podcast and share your expertise in this area, because chronic pelvic pain is complex. And
it's one of my passions, trying to get this information out there. And I think so many women get dismissed with some of these symptoms, and well, anybody who suffers from chronic pelvic pain, it's complex, like you said, to figure out. And so I love being able to shed some clarity and help people figure it out.
Well, thank you. So why don't you tell us a bit about yourself before we dive into this fascinating topic?
I've been a physical therapist for about 10 years now, and I myself have hypermobility and chronic pelvic pain. And it was things that I didn't know were really a problem until I got into the profession. I was a ballerina when I was growing up, and I'd always been, quote, double jointed. And during my practice, a pelvic floor therapist came into our clinic, and we got to talking. And the more I worked with her and the more we had conversations, the more I realized that the things that she was treating, I was missing in my practice. That was a whole section of patients that I was missing out on, that the patient that isn't getting better, that you can't quite figure out why. That was the missing component, was they had a pelvic floor condition that I wasn't able to screen for. And so we both ended up learning a lot from each other and developed this really great symbiotic relationship where we collaborated all the time. And so now I've taken what I've learned and I've put it into our residency program that we have. And I guest lecture at some of the universities and things like that to really show where that overlap is with orthopedic conditions and pelvic floor conditions. Because in PT world, we want to keep them really separate. And in medical world, we want to keep them separate too. And we forget that they're muscles that impact our hip and our spine and the way that we move and walk and our day-to-day function.
Wow. So tell me a little bit about the nuance of the area that you specialize in versus some of the colleagues, because I will say on the Fempower Health podcast, I've done tons of episodes on chronic pelvic pain. Actually, a lot of them just stem from pelvic floor PTs coming on the podcast and sharing different things that they're working with patients on, not even just from a specific condition, but just navigating the complexities of the pelvic floor.
Right.
And I'm noticing there's like all these subspecialties almost within that. So maybe you could just tell us kind of the nuances of what you do versus your colleagues, and then we can dive into everything that we need to help educate women on.
Absolutely. So I'm a board certified orthopedic specialist. So I treat everything from neck pain to knee pain, post-op, chronic pain, all of the things. But pelvic floor is one of those, niche kind of subjects where you have to take special courses and be certified in order to treat those specific conditions because of the internal exam component, and then because pelvic floor is so complicated within itself. So I do not do any of the internal work. I am not a pelvic floor therapist, but working with my pelvic floor therapists, we echo a lot of the same things, and I'm much better equipped now to recognize where the overlap is and how to treat pelvic floor from the rest of the functional perspective versus just the pelvic floor muscle dysfunction versus just the incontinence components or the bowel bladder dysfunction, the sexual dysfunction. So
that makes a lot of sense.
That's where my kind of niche, like my role comes into it, is the overall neuromuscular re-education of everything, trying to figure out how to get back together to function appropriately after someone's had pelvic floor muscle dysfunction specifically.
Okay, got it. No, that makes sense. And I find the more subspecialized someone is, I'm noticing that they understand their, I guess, parallel, so to speak, specialist, subspecialist counterpart, so you all can refer to each other. So I'm seeing that here, that parallel almost with your pelvic floor PTs. And then probably there's sexual medicine specialists that get involved. So this is the chain. And I like to start this because, you know, I nerd out on this stuff, but too, I want women to kind of understand upfront, like this is complicated and you do have to find the right expert. And luckily the subspecialists seem to usually know the nuances that not always an OBGYN would know. And again, it's not a knock on the profession. It's just the dynamics of how the healthcare system is playing out.
100%. And that's one of our huge frustrations too. I mean, I remember when I was experiencing pelvic pain for the first time and my pelvic therapist friend reproduced my pain because the GYN couldn't figure out what was going on. She's like, I don't know, you don't have cysts, you don't have this, you don't have that. I don't know why this is happening. And after a couple of treatments, I was better. And I went back to the GYN singing praises of like, look, we figured this out. And she was like, neat.
Oh, that's the worst.
I gave you the holy grail. And it's just the way that unfortunately our health system is structured. I will say I'm glad to be seeing it changing a little bit. We're seeing a lot more referrals coming from Urogyn and coming from GYNs. And actually our hospital system has implemented now a mandatory, like an automatic referral for any person who's postpartum to automatic
finally
referral. Mm-hmm.
Oh, finally.
So
oh my God, that's amazing.
Come.
Right.
But they always get the call, they always get the education on it, and then they're educated to come do their 6-week postpartum follow-up to make sure everything is healing up as it's supposed to from a pelvic floor standpoint.
Okay, got it. All right, so let's dive in and talk about hypermobility. So like you, I have hypermobility. And I used to think it was I didn't know it was hypermobility. So I remember taking gymnastics and we would do stretching and I'd be like, I don't understand what we're doing. Like I would be the one that could do the split and then you get the yoga block and then you put your leg on top of the yoga block while you're doing the split. Yeah. Well, now I'm training for a marathon and my pelvic floor is screaming loudly, why are you doing this? So the impact of hypermobility. And I think a lot of us don't realize that this is not always the best thing in the world to have. Like it looks cool, Cirque du Soleil, but from a health perspective, it causes a lot of problems.
It does. And people are like, oh, well, you have so much flexibility. Like that's great that you can still contort yourself into these positions. And part of me is like, man, I am just waiting for that arthritis to kick in though, so that I get a little more stability.
Tell us about hypermobility and pelvic health. Like how does this tie together?
So hypermobility as a definition, like especially when we start looking at, you know, somebody who's got a lot of hypermobility, this hypermobility spectrum disorder where you have multiple joints and it's a true connective tissue disorder. It's not like you just happen to have some really flexible thumbs. It's a systemic connective tissue condition.
Really?
Which affects blood vessels, your digestion. So yes, we can definitely dive into that if we haven't gotten there yet. So from a pelvic perspective though, so when you have muscles and tendons and ligaments that have increased extensibility, they're more flexible because they've got different qualities to their connective tissue. Those muscles have to work twice, 3, 4 times as hard to do their job as somebody who's got normal levels of stiffness of their tendons, ligaments, and muscles. So the pelvic floor's job is to create stability within the pelvis. So it creates that foundation point for the spine to function from, for gait, stair climbing, all of the things that we do throughout the day. But then it also increases our intra-abdominal pressure, which also stiffens the spine and creates some of that spinal stability. So if you have increased tissue extensibility and you're more flexible, those muscles don't always have enough strength to do their job, and then they can go into dysfunction. they can become deconditioned and really weak and not be able to do their job, or they'll try to do their job so hard that then they end up in that kind of spastic, hyper contracted state where they're just constantly in dysfunction trying to hold everything together and create stability, which then leads to more problems with the pelvic floor dysfunction.
So, I'm trying to how would someone know if they have hypermobility? Let's start there. And then I want to understand, if you do have it, what are the things when you're saying it has all this impact? We've talked about the structure, but like what will be the long-term impact if you do have it? Right. So let's talk about hypermobility first.
So when a person's got hypermobility, these are the people that, you were told you were double jointed when you were a kid. Maybe you could do the splits when you were younger, or, you sit in goofy positions with your knees, folded up at the table all the time. Mobile people also tend to wiggle a lot. They have a hard time sitting still in class sometimes, or even at home watching TV. They're the people that are folded up on the couch in a little ball and then constantly changing positions because their tissues start to stretch out and it feels uncomfortable. So then they change and they move and to try to kind of reset, if you will, their system. So that's one thing that people will notice. The big thing is the double jointed component is so people realizing how flexible they might be specifically in their knees, hips, shoulders, fingers. So there's the Beighton scale is one tool that we use, and it's a real simple look at, do your elbows hyperextend? So when you straighten your elbow out, does it bend past the straight line? Right. Same for knees, fingers, do they pull past 90 degrees? Can you touch your thumb to your wrist? And then being able to stand up and on the floor is the other one. So if you have enough of those you have to have it in multiple places, right? So the other thing that people might suspect hypermobility with is if they have digestive issues, if they also have chronic pain, if they have TMJ issues, if they have migraines. Those are all things that are associated with having that increased tissue extensibility throughout their entire body. But the cardinal sign is that flexibility throughout in multiple joints.
So I want to go with how do we fix this? I want to go straight there, but let's try to take this apart. So we talked about what it is and some of these symptoms, but from what else could be happening? So this digestive thing, I almost want to dive into because I have found, because my son had some issues that took us years to navigate with clinicians, because I find that if there isn't a very clear treatment or a diagnostic, it's hard to invest the research dollars.
Yes.
And people just aren't as invested in it because there's not a lot of revenue to be generated. And so I could imagine hypermobility and digestive issues falling into that category of why do research? Because what's going to be the treatment? I'm assuming a lot of your work is going to be the treatment. So can you help me understand why hypermobility and digestive issues are tied together?
Yeah, and you're right. There's not a lot of research that specifically looks at that. We just know that it's associated, right?
Okay.
So, and it falls into that category of IBS, which is that catch-all of we don't really know. You vary between constipation and diarrhea all the time. You maybe sometimes you're more sensitive to foods. A lot of people, it manifests as GERD, like the reflux, and heartburn, and it doesn't follow the typical patterns of it only happens with spicy foods or, something like that. So it's the theory behind why it tends to happen that way is that there's some theories about just overall systemic inflammation, that people with hypermobility just might have more sensitivity to some things and certain foods, and it's different for everybody. But the other part of it is your digestive tract itself also is more flexible. And so it doesn't have the same strength of contractility and being able to push things through. And
Wow.
then and then if you've got pelvic floor dysfunction or you've got inflammation from something like that, leads to more that leads to more pelvic dysfunction as well.
Interesting. And so what are some of the pelvic floor dysfunction things that can happen? Obviously, I know prolapse is one of them. What else should people be
Prolapse
aware of?
for pelvic floor dysfunction in general
Mhm.
or related to like the digestive component?
I would say related to hypermobility, but I mean, you're the I would say you're the expert, so I don't know what I don't know. So I would say, what should we know?
So the pelvic floor stuff that's going to be associated more with the hypermobility is usually going to be more muscle dysfunction. It's
Okay.
going to be because you don't have enough stability in your spine and your pelvis to move and do the things that you need to do. So your pelvic floor is going to contract or be too weak to do its job. So that's going to manifest with incontinence issues or pelvic pain or pain with sex, pain with tampon use, things like that, even bowel movements too. Then the other half of it is having irritable bowel, having this back and forth of constipation, diarrhea, and then the way your diet can influence the levels of inflammation that you have in your colon and in your gut. There's a really interesting phenomenon that happens within the pelvis, and it has to do with the way that our nervous system is wired and how our brain perceives where sensations are coming from. So, inflammation in a pelvic organ actually impacts the muscles too. So, if the colon is inflamed with IBS, the pelvic floor muscles themselves can also become inflamed and reactive, and you'll get pelvic floor muscle dysfunction from that. And so then they start going back and forth and feeding into each other as well.
Wow. So then, from a pain component, I guess, is it always, I guess, where does the pain aspect fit in? And I'm asking because I'm assuming people may not always experience the pain, and maybe
Right.
people experience it to different degrees. So,
Yes.
because I think, it's always interesting to me, like what brings someone to a doctor, right? And with women specifically, after having done this podcast for 5 seasons, the themes I see are women will go to a doctor to get birth control. Women will go to a doctor when they're struggling with fertility, and women will go to a doctor when they're pregnant. And then some are proactive and just go diligently every year to see their OBGYN. And then the next time is really when they're severely struggling with something, but it's not something when it's a small thing. And so, I'm just curious because for those who aren't experiencing pain, I want them to be aware that just because they're not in pain doesn't mean something's not going on. So tell us about
Yeah.
the pain, hypermobility, pelvic floor dysfunction, and how all that ties together and why it may not manifest the same in everyone.
So if it doesn't manifest in pain, then it can manifest in incontinence issues for one, or even constipation, because sometimes the constipation's not actually from the stool, it's from the pelvic floor muscles being in dysfunction, right? And being too tight, not being able to have the correct sphincter control. So, and it doesn't have to be painful. A lot of people it is, but so that may be one way that it manifests. And then we had mentioned pelvic organ prolapse. That's also one way that it can present as well. And that's oftentimes not painful. And it does happen more often to people who have hypermobility as well. The other thing that can happen, because you don't have to have just straight pelvic pain with it either, it oftentimes manifests with hip pain, low back pain, and people will complain a lot of that sacroiliac joint region, that SI region, kind of like between where your cheek and your low back meet, is the other place that people complain about pain.
So I guess, how do we rectify this and repair it? Because I even think about my journey. I mean, obviously, I can't do the splits I used to do. And I do feel like once I had my son, things change, not in any major way, because I'm lucky I don't experience a ton of pain, and I even have endometriosis. So if you have a relation there to also add, I'm dying to hear what you may
That
have to
too.
say. Like, I'm fascinated because I feel like I'm the asymptomatic person that has everything that you're describing. So it's like
Uh-huh.
our body is just like, it's so crazy.
It's wild.
So yes. And so I would assume there are things like pregnancy, vaginal delivery, even C-sections. People think C-sections mean no pelvic health issues. And I'm learning that is incorrect. Just because the baby doesn't go through the vagina doesn't mean there isn't an issue. So I don't know. I guess tell us about how these life stages can impact us, the role of endo, like how does it all continue to manifest with this foundation of being born hypermobile?
So let's focus on pregnancy, because that's really
Please.
where we see it manifest for sure.
Okay. Okay.
With it, because oftentimes we have more tissue flexibility in general when we're younger. And so you'll see even high level athletes like gymnasts, like Olympic gymnasts, will have pelvic floor dysfunction and incontinence because they're so strong everywhere else, but their pelvic floor hasn't been able to do their job. And that's not, a typical person that you would suspect having an issue, right? So that's one life stage. But then when we start getting into pregnancy, when you're pregnant, your body releases relaxin and other hormones that make you more flexible, because your pelvic bones need to be able to separate, right, to accommodate a baby that's growing in there and then to accommodate delivery. And so this can manifest with increased sciatic type pain, increased pelvic pain in general, increased low back pain. And it usually happens sooner in the pregnancy for hypermobile people than it does for those that are not hypermobile. But, those kind of symptoms are common. It's common for anybody who ends up pregnant, but significantly more for someone who's already hypermobile.
Okay.
And then all of those relaxin hormones stick around postpartum while you're breastfeeding. And so you can have increased hypermobility when you're already hypermobile. And so people will continue to experience back pain, pelvic pain postpartum for longer periods of time. And then, the fact that you've pushed a baby through your vagina disrupts your pelvic floor in general. But actually, with the C-sections, we see a lot more dysfunction with that because you've cut the abdominal wall. So now you've created another injury and another disruption to that stability system. And so now you've taken away the core muscles that were creating pelvic stability. So you've got relaxin working against you, you've got your hypermobility working against you, and you've got no abdominal muscles now. Plus you're exhausted because you've got an infant. So it's a lot.
That is a lot. So I guess there's kind of two ways that we could take this, and maybe both are important, which is one, like if you know you're hypermobile, what is it that you need to do in order to mitigate all of these issues? And then if you have those issues, what do you do? Maybe we could start with the mitigation and by the things that you should do in your life to not make it worse. What are the things you can do to be proactive? Because we're seeing there's a lot of impact if we're not monitoring it.
100%. So along that line, I typically tell people like nothing's off the table. And, lifting weights is great. Lifting heavy weights is fine. The problem that I end up seeing is that people will lift heavy weights, and bodies are really smart. Bodies will recruit the muscle that's strong enough to do that most of the time. But then you're training the big muscles and not training those smaller muscles that need to be supporting those big muscles. And your body can do that for a little while, but then it starts getting tired of doing that. And then it starts having little tiny injuries that you maybe aren't even aware of. And then it turns into a bigger injury. And you're like, I've been doing squats for 2 years. Why is this bothering me now? And it's because your pelvic floor literally can't take it anymore. So my advice would be you have to start smaller and train up to those higher levels if weightlifting is something that you want to do. But the successful way to mitigate some of the hypermobility issues is to really focus on those smaller stability muscles. Specifically, I don't want to get too nitpicky here with specifics, but glutes, super important. So glute max and glute med. A lot of times we forget about gluteus medius, which is the little guy on the side. And that also strengthens your pelvic floor. And then your deeper core. So it's not doing crunches. It's not using that big six-pack muscle on top. It's using that deeper core muscle, your transverse abdominis, that runs sideways and connects to your low back and creates that stability and that intra-abdominal pressure. So exercises that are really successful for helping with the hypermobility component that I use a lot in clinic and recommend to people are things that require some static stability and then progressing into like a mobile stability. So Pilates is a great thing to do, whether it's mat, reformer, standing, those bar classes. That's why why you feel like they helped you so much more is because they focus on those tiny little stability muscles. It's all about having a stable central core and then doing other things that make you use your internal stability versus being able to like use the big muscle to do the thing.
Right. So a question there is, I found, like, to me, it's all in the nuance. So someone could go to these classes and still have issues. Like, for example, I know that when I was doing too much of the bar classes, my hips were bothering me.
Yep.
I know that with Pilates, I had a friend who's training to be an instructor, and I've done the reformer classes. And I will tell you, when I did the private with her, barely moving my legs, it was way, way harder than going to the reformer and trying to be all hypermobile with how far my legs would go, this, that, and the other, thinking that I'm building the core, but in fact, not as much as when I was barely doing anything and doing proper form. And so, I want to make sure that people understand that form is so, so important. So what are some of the mistakes that you're seeing people make? I mean, at a high level, I would say just assuming going to these classes is enough because it's doing the exercises right, even within them, right?
Right. It's about doing them correctly within them. And that's the really hard part because there's, not all classes are created equal. I was a big yogi too for a while because when you're flexible and you can hit all of those end range poses, it's super fun, right?
That's right.
But I've modified my practice to focus more on the stability part. I don't do the back bends anymore. I don't need to. My back's flexible enough. So I'll hold a plank instead. I don't hang out in those like bottom end range motions anymore. I maybe come out of it a little bit and then force my muscles to hold me for a little while. So there's little modifications that people can do, but you have to kind of have the knowledge in order to do that, right? And not all instructors have the education or the ability to be able to do those kinds of things. So it's hard in the classes sometimes to really find but if you can get a class where, especially if it's a beginner class, where somebody can like really sit there with you and focus on what the correct form is, that makes a big difference. Or finding an instructor that's cross-trained in a lot of things. Like there's actually a lot of PTs that teach bar and Pilates on the side all the time. And so that's another way to get in there because they've got a little bit extra knowledge in some of the things to do. And it's not like they just took a weekend course to learn the routine,
Right. No, that's true. And if someone can afford it, maybe take one private and just say, look, I have hypermobility. Right. What are the things? And just have it as a very specific, teach me how to do this correctly so that when I'm in the class, I don't try to follow and overperform because I'm so cool and hypermobile. Because it is exciting to be flexible. I know I sometimes go a little too far and it's just like, I probably shouldn't have done that.
It is. Yeah, it is.
Yeah. Okay. So you alluded before, and I don't want to drop this for any of the endometriosis patients listening, but you kind of were nodding your head. So what do we need to talk about with endo, this hypermobility, pelvic pain dynamic?
You know, I wish I had more information on it. We see the overlap. I don't know. We don't know why. Because endometriosis, you don't have to be hypermobile to have endometriosis. And there's lots of, 1 in 10 women has endometriosis. And endometriosis itself presents in so many different ways. You can have somebody that's got a really severe case but doesn't have a lot of pain, and then somebody who's got a mild case but has a ton of pain. So I don't
just
know
complicated.
why it seems to happen more. I mean, maybe a personal theory I have with it is maybe people who are hypermobile because they experience more pains and they go to the doctors more frequently. Maybe they're getting more of a diagnosis with it because they're investigating things. Maybe because they have other problems already, they are more sensitive to their endometrial symptoms. And so they're getting more of a diagnosis. It could be something as simple as that versus, from a scientific perspective with it.
Yep. Okay. No, that makes sense. So from the pain aspect, we kind of started to go down the road. Again, this is like so complex. You kind of have to almost like interweave it all because it almost is like this web, right? And so for those listening, apologies, we keep maybe going all over, but it's kind of hard to be linear about something so complicated. From a pain perspective, I know there's different ways to manage pain. And I'm thinking about how you were saying the ability to, I can't think of the word at the moment, repeat the pain and show it in the doctor's office. And you can't always say, today we must call my pain because I'm at the doctor's office. Like we don't always know what's causing it, right? Yes. And I'd actually interviewed Melissa Farmer a couple of years ago, and she was like one of 5 people in this entire country who is trained in all of these sub areas around pain. And it was really, really interesting to talk to her about the research. But maybe you can tell us about the pain association as well with hypermobility and what to do about it.
It's complicated. It's also the answer. I know.
Yeah, we're going to have a pill for this.
If only. There's hypermobility and pain it's complicated because there's several different kinds of pain, right? So people with hypermobility, one, they're more prone to injuries, if you will. They're usually more clumsy. That's the, lay term that people will use. They run into things, they trip and fall down, things like that. And it has to do with being more flexible, and your brain can't quite tell exactly where you are in space. And so you fall down more. So they'll get more acute injuries like that. They get more ankle sprains, they get more strains and sprains, things like that. So you can get pain from that. Some people suffer more from numbness and tingling in places that don't fit a neurological pattern. I see that happening less with the hypermobile people, but there is a little association with that. But from a chronic pain perspective, and chronic pain in itself is super complicated, right? Like we could talk for days about that. So the short version with the hypermobility is your body's getting such different levels of feedback for what movements and input and places that your joints are and your tissues are and things like that. Like you're just getting so many signals that your system can become more sensitive to things. And so then your actual like little nerve receptors that detect pain get more sensitive. So they start sending signals sooner than maybe they necessarily need to. And your brain can kind of attune to those more than they need to as well. Just being, because hypermobility has so many comorbidities with it too. So depression and anxiety are associated with them too. And having those changes in your endorphins and neurotransmitters also kicks up your pain centers. And so you'll see more of an association of chronic pain with that as well. So if I had to put it in a nice little envelope of how hypermobile people could take care of themselves, It's addressing yourself from the mental health perspective, from an overall wellness perspective, with hydration and that kind of thing. Regular exercise, and it doesn't have to be anything big and crazy. Exercise really makes a big difference for people, even if it's just taking a walk. But those smaller stability exercises make a really big difference for long term and staying active, because as we stop being active, we get more deconditioned, we get even weaker, and then it just cascades and usually ends up getting worse from a pain perspective.
So it sounds like that foundation is important.
The foundation's important, and then keeping up with some kind of that foundation. And then there's so much research too that shows just regular activity, even if it's a 30-minute walk a couple times a week, that has enough impact from an endorphin standpoint and from a nervous system standpoint that it starts down regulating your nervous system from a pain perspective. And so it actually does reduce overall levels of chronic pain as well.
Wow. And I'm sorry, I interrupted you. You were saying about physical therapy as well.
Physical therapy is also a great place to go. If you need the jumping off point, if you need help figuring out why does this hurt, but this doesn't, and especially from the pelvic pain perspective, because sometimes exercise makes pelvic pain worse. And so seeing a therapist who can diagnose, are you at a stage where you need to rest and we need to do some tissue recovery? Or are you at a point where we need to train at a really low level so that you can tolerate the bigger things and help guide that process, makes a really big difference.
Interesting. So I guess if we were to take a person who's dealing with chronic pelvic pain and has hypermobility, obviously the foundation is important, right? That we just addressed. But I guess I'm just thinking of, you've got sexual medicine specialists, you have your specialty, you have the pelvic floor PT who will work internally, you have your OBGYN. I mean, there's the urogynecologist, like there's all of these specialties. And I'm not at all saying it to overwhelm.
Right.
I'm just so curious, like the dynamics of it, because it's like chicken or egg, right? And we know that one of the key foundations is hypermobility, but we can't necessarily say it's always because it's hypermobility.
No, and it's usually just a component.
Right. So I guess if you were to, advise someone, and again, I know it's not a straight shot, like linear, do this, this, and this, and then this.
Right.
But if you maybe could just given all the patients that you've seen, is there a theme of how someone should navigate the healthcare system as they work through this situation?
It's going to vary state to state too.
Okay.
Because not all healthcare systems are created equal. So where I currently operate, we're a direct access state as physical therapists. So you don't need a referral to come see us.
Okay.
So you don't have to go to your primary care doctor. You don't have to go to an OB to come in and see a physical therapist or even a pelvic PT. I think a clearer way to try to navigate if you're experiencing chronic pelvic pain is you do want to rule out, is there something larger medically that needs to be addressed? Is there a fibroid? Is there a cyst? Rule out the big cancer, things like that. So probably starting with, if you have to start with your primary care, that's where you go. And then going into a GYN, just to make sure that from an organ standpoint, everything's functioning for the most part. And anywhere along that line, either at the primary care office or at the GYN, you can request a referral to physical therapy. And you should be able to be co-treated. So while you're doing your diagnostics for the GYN workup, you can go to physical therapy and get that process started as well. You can also go directly to a physical therapist, and if they're, good at what they do and they're within a good system, they can send you where you need to go. I'd say navigating PT can be hard too sometimes because not all PT places are created equally. So I'm fortunate enough where I work, I'm in a hospital-based system, which means that I'm in a clinic where I'm one-on-one with my patients. I have an entire hour with them. I'm never double booked. So I really get that quality time because it's hospital-based is a buzzword, one-on-one patient care is a buzzword, and then a nonprofit as well. And
Okay.
so then looking at what your PT qualifications are. The PTs from a pelvic perspective, especially if you're a complicated case that you're going to want to look for, are somebody who's got maybe a credential of a PRPC. It's a pelvic rehab practitioner certification, I think.
Sounds good to me.
Not the one that I've got. Or a WCS, which is
Okay.
a women's certified specialist. They're trying to change that name because it's not just women that have pelvic floors. So they're
Yes.
trying to change that to just general pelvic floor. But so those are the two advanced training, like alphabet soups that you'll see after somebody's name that can indicate that they may be at a pretty good qualification to help guide you in the process on where they need to go.
Okay. That makes sense. And, what I would almost add to this is however you enter into the healthcare system, and as you go through it, tell all the clinicians you have hypermobility. And if you don't know if you have it, I'll put in the show notes the thing that you can at least look at as like a baseline to just, then it could be I think I have hypermobility, let's talk.
Yeah.
But then I would reinforce that even if there is a clinician who isn't trained in this and dismisses it, it's really important to know that it is
Yes.
something that's going to impact your health. And so
Yeah.
this is where I start is like, how do you advocate? Because, I hear so many patient stories, hear them from clinicians who are working with women who are struggling to navigate the system. And it's kind of like this, doctors can't keep up with everything. Patients know
Right.
their body, so they can hopefully research something very specific to hopefully like raise the alarm with the doctor who may or may not know it because they have too many things that they're trying to keep track of, and guidelines
Right.
and things like that are constantly changing, right?
Mm-hmm.
Yeah. And I
Yeah.
have found too, like we were saying at the beginning of this call, that the subspecialists tend to know the other subspecialists in other categories, and there kind of can be a cross reference because you may go to a sexual medicine specialist if you're having sexual health issues, and they may say, oh, actually, you should see so and so. But I think every single
Yep.
one of these, you have to say, I have hypermobility. And I even admit I forget to tell them. And as I'm talking to
Yeah.
them, like I probably should add that to my list to make sure I tell
Yeah.
my doctor every time.
I think it's important for patients to say those kinds of things. And
Yeah.
unfortunately, you do have to be your own biggest advocate. Unfortunately, I think hypermobility gets kind of pushed to the side a lot of the time in medicine. And part of it's because everything is so complicated anyway. And a lot of people don't know what to do with the hypermobile patient, and they don't really understand how that impacts everything that they're working on either. So
Yep.
I think you have to say that. And if you have a physician then that's dismissive of it, I would say that's a red flag.
Yeah, for
Because
sure.
any clinician that really cares, if you bring up something that they don't necessarily know about, they're going to say, I'm going to take that into consideration, or I'm going to look into that a little bit more, or tell me what that means to you, at least to get the patient's perspective on how they feel like that impacts their recovery.
Yep, absolutely. Oh, before I forget, I should have asked this before we kind of got to this part, but menopause and hypermobility. So, is there any sort of other impact that we should consider because of the estrogen and progesterone and many other hormones changing? Does that have any sort of additional impact, or can we kind of keep that to the side, or do we just not know yet?
Personally, don't know much about that.
Okay. Okay.
I don't know because there's arguments on if hypermobility has an estrogen component with it because it does seem to be more prevalent in females.
Interesting.
But we also don't know why. And so anytime something's more prevalent in women, the automatic response is it's got to be estrogen related, and that may not be true. From a clinical perspective, I don't think I've noticed too much of a change from hypermobility specifically. I know sometimes it can change your pain perceptions a little bit because of the hormonal component, but I don't see necessarily a reduction in how flexible people are or anything like that. It's actually usually the natural aging process of just bones and joints getting stiffer as we age that tends to change things more for people.
Okay, that's fair. And then I guess going back to something like digestion, we talked about the foundation of staying healthy if you're hypermobile. So let's say I'm doing that and still have digestive issues. Because I guess I'm just thinking, like, it must be so frustrating. Like, I know with my son, 4 years of being in tears, navigating and pleading and begging with these doctors. And I work in the healthcare system, and it was so frustrating. And by the way, my son has hypermobility. So it's just like, yeah, I mean, is it just these are hard and you just have to keep troubleshooting for whatever works for you? And hopefully something will be the magic that finally helps. But just know the hypermobility component, at least you can control the get stable part. And then hopefully the other thing is you just find the right clinician. I mean, is that kind of where we're at right now?
Unfortunately, yes. And every single person is different. One of my besties is also, and she's a PA too. So, she's in the system. She knows more about a lot of things than, the average person does. And she even has a really hard time navigating stuff. She's got way more digestive issues than I do, but I have other issues that are more than her, even though we're both about the same on the flexibility scale and things like that. So it's so different person to person, and it manifests so different in every single person that, it is. It's about finding what works for you. She finds that she's really sensitive to fiber, but then that's one thing that really helps my digestive stuff is making sure I get enough of it.
Okay. There you go. I mean, but I guess at the end of I know. And I've actually just published an episode on trauma and pelvic pain. I mean, talk about adding another component into this, right? Again, it is complex. And I mean, for me, I think it's fascinating. But then when you're struggling with it, it's like, I don't really care that this is fascinating. Can you please just tell me the magic pill and make this go away? So I fully acknowledge that. But I hope that as people listen to these series that I'm doing on chronic pelvic pain and I'm about to do an episode on scoliosis. So it's just, it's both fascinating, but hopefully these little pieces will help someone put the puzzle together for themselves so that they can advocate and navigate. But I think we all agree it's not this perfect thing. It's very imperfect and individualized. So
yes. And I think that's the point that I really want to drive home too, because when you're in the thick of it, you can start to feel crazy.
Yeah.
You can start to feel like, am I really being too sensitive about this? Is there really anything wrong? They say there's nothing wrong with me. And so I want to validate people out there that are struggling with this, because it's hard and it's complicated and you're not crazy.
Yeah. What other tips and what do you see as the future with is there a future? Is that even a fair question?
I know. My hope for the future and where I hope we end up going is that we get a much better increased awareness of all of this, and that the medical community in general gets a better idea about it. And so, because if we can start having some interventions with people when they're a little bit younger, I think that would be great. So I wish when I was younger, knowing that it's really cool that I can do all of these contortionist things, is that going to be best for my longevity? Maybe not. So are there things that I should be doing to cross train to keep my body the healthiest, knowing that maybe I shouldn't be sitting in one position for 4 hours like a little book goblin reading, and that I need to get up and take breaks. Knowing how and when to listen to your body, learning some of those things. I hope that we figure out some of the digestive issues, because I think that would improve people's quality of life significantly. I don't know what the answer is for it, but I hope we figure it out one day.
Yeah, it's helpful, and really appreciate that you're working so hard on this. And
I'll say again, to find somebody who can really spend the time as well is looking for a place that's one-on-one, hospital-based, nonprofit. That's where you're going to have the more likely opportunity to get a clinician that can give you the dedicated time, because it's really hard when you're in a typical PT private practice where you've got 4 patients at one time and you only get 15 minutes with each patient before you pass them off to somebody to do exercises with them. So finding that kind of a clinic, I think, makes a really big difference. And you can always call the clinic and ask too. That's actually how a lot of people end up finding me, is they call the front desk and they ask who's good with this particular thing. I'm one of the only clinicians in my building that treats TMJ. So people call and ask who does this, and it's only me. So they automatically get sent with me.
Got it.
My front desk knows that chronic pain is my deal. So if anybody calls and sounds even remotely complicated, they end up on my schedule.
Okay. Got it. So that's interesting. I never thought, because I just always thought, hey, you're referred to PT, just go to PT when you have your prescription. I never thought to say, this is what I have, who would do this. So that's a really great, really
when you're
great
scheduling,
tip.
ask.
Okay.
Absolutely ask, because there's
really helpful.
And even if you don't and you end up with somebody, I think if they're a decent clinician, they will say, I am not the right match for you.
Okay.
And I think you should see my colleague, because I do that. I get the people that, they're a 17-year-old sports injury, and I'm like, no, I need
the chronic pain person.
Go with one of the sports guys. They're going to be able to play a lot more ball with you.
Alyson, thank you so much for making time for this. This was an absolutely fabulous discussion.
Thank you so much for having me.